I'm Heather Nelson. I'm a faculty member in the Division of Epidemiology, and I'm thankful to have other colleagues from the Division of Epidemiology here today. So we have a team of speakers today. Simon Rosser is Professor of Epidemiology and the Director of the HIV/STI Intervention and Prevention Studies Program. He is joined by two doctoral students, one from the Division of Epidemiology, Elizabeth Poulter, and Morgan Wright, who's in the College of Education and Human Development, and they'll be joining him today. Simon has his PhD in behavioral medicine from the Flinders University of Southern Australia, correct?
Yep.
Yep, although he's from New Zealand, so don't get it confused, is that correct? Okay. He then went on to get a fellowship in sexology from the University of Minnesota, as well as an MPH in epidemiology, and joined our faculty in 1992. He's had a really distinguished career in HIV and AIDS prevention research, and we're fortunate that he made a pivot several years ago to cancer research and studying sexual and gender minorities and prostate cancer and cancer survivorship in this population. He's new to the MCC, he's got NCI funding, and he brings expertise in a new area, both for MCC and a place that the NCI is really focused on, which is increasing research in sexual and gender minorities and cancer survivorship. And he brings a nice overlap to those two areas of emphasis. And so he's going to tell us about their study, Restore, with his team. And he's just been telling me about all of the R01s he's submitting in the next few months, including, it sounds like, 3 that are cancer focused. Mm-hmm. Yes. So Simon, thank you.
Well, good morning, everyone, and good morning to the remote sites as well. It's a great honor and privilege to be here. I still feel like I'm one of the newer cancer researchers, so I'm a little bit nervous about the cancer aspects. Please be gentle with us. But I've been studying gay men's health and sexual and gender minority health for all my career and specialized in that. So hopefully we can do a nice blend. I thought today what might be helpful is to talk about and provide answers to 7 questions. The first one is, why is cancer in sexual and gender minorities an increasing priority at NCI? What's going on there, and where is the future? Second is just, why study this area at all? The third one is, so what are we learning from our R21 study that was completed? Fourth, there's some interest in how do older gay and bisexual men differ from younger gay and bisexual men in Restore 1. And an intriguing question that one of my doctoral students is going to enlighten is, do pets help populations who are more isolated or not? And at least in Chicago at the national meeting, that turned out to be a hot topic. And then it's my pleasure to update you on where we're at in Restore 2, which is the first R01 on this population that NCI has ever funded. And then finally finish up with where can we get some more information. And so that sounds like a suitable agenda. Does that sound good to every? I see people in the room nodding, so that's good. Okay, so let's talk about sexual and gender minorities, and that's language that NIH uses. What we're talking about is lesbian, gay, bisexual, and transgender people. That's people who identify with those labels, as well as people who behaviorally or affectionately might be included in the population who don't identify with those labels. And basically, at the population level, we comprise about 4.5% or 11.5 million of the adult American population. But the population is very skewed, particularly important when you're thinking about cancer studies. We are very disproportionately female and disproportionately young. And that's because we think about 600,000 gay Americans died of AIDS. And so we've got a large population missing there. And then also suicide. We lose about 1 in 3 of our population to before they're adults to suicide. So there are large factors that skew the population. And that's also important to consider because some of these are historical. that we've got large populations who now are aging into populations. So clinicians should be expecting to see more sexual and gender minority older adults in the coming decade. So back in 2010, NIH elected to do an external review of research around LGBT health, and they wanted to answer the question, what are we doing well, where are the gaps, and what's happening? And the report came out, and they said basically that NIH and science is failing the American population because of the lack of studies on this population. Obviously something that NIH and everybody else didn't particularly want to hear. They actually used prostate cancer in gay and bisexual men as an example where before our study, there was an RO3. I have just summarized the entire literature and history of cancer research and prostate cancer research in gay and bisexual men. So this is a population where there are large gaps where we don't know anything. In response, Dr. Collins at NIH established the Sexual and Gender Minority Office out of his office to be a trans NIH-wide institute. In 2017, the United States Congress passed 2 bills mandating NIH to increase funding on this population. So NCI is now out of compliance with federal law, which is a big deal if you happen to work in a federal agency, unless they increase this, which is one of the reasons why we're starting to see RFAs come out with targeted funding for this population. 2019, NIH officially recognized and defined sexual and gender minorities as a health disparity population. And you can see up on the screen the definition. Rather than talk about LGBT, they're using language that mirrors racial and ethnic populations, and with the idea of treating them equivalently. So SGM populations include, but are not limited to, individuals who identify as lesbian, gay, bisexual, asexual, transgender, two-spirit, queer, and or intersex. And then people with same gender attractions, behaviors, and those with a difference in sex development are also included. Sexual and gender Dr. Kent at NCI and staff at NCI have just reviewed the area, and they came to the conclusion that sexual the experience and needs of these underserved populations in cancer care delivery. There is some evidence that across various cancers, that cancers in women are disproportionately in lesbians and bisexuals, and that some cancers in gay and bisexual men are also disproportionate, including lung, anal, colorectal, possibly oropharyngeal, and of course the HIV-related cancers. Sorry about the slide. This is for the doctoral students here. When you're presenting, you should never present a slide that looks like this slide. But I wanted to, because I want to make the slides available and give you the references. Over half the slide is the references. But at every stage of the cancer care continuum, you can argue that sexual and gender minorities have higher risk factors. That's well known. Lower insurance rates, less screening, less familiar and social support, later diagnosis, more distress, unique challenges, especially whether or not to come out to their cancer specialist, less culturally competent care, worse quality of life, and worse morbidity and mortality. So this is important if we want to keep people alive. So the significance of the Restore study, as I mentioned, we're very understudied. In 20 years, NCI has funded approximately 29 awards. That's 1.5 awards per year. Many cancer trials with sexual sequelae explicitly exclude SGM. So not only are they don't have the special studies, we're systematically excluded from the existing literature, and that's for a good reason. I mean, if you wanted to study the sexual sequelae, you want to study the effects of sex on, say, vaginal intercourse, then you remove populations where that's less likely to occur. I I spent about 3 months last year talking to key informant interviews around the United States on what's going on and why this is happening. Importantly, NCI really emphasized it's no lack of goodwill on their part. This isn't homophobia or anything else going on. They're just not receiving the applications. And so there's a gap there. And on Christmas Eve, they released, for example, RFA CA 005 calling for more applications, so it's dedicated funding. The significance of Restore. This is the first R21 study on prostate cancer in gay and bisexual men that was funded by NCI, and then Restore 2 is the first R01. So you're sitting at the university with the most research on this population. So let's turn now to why should we study this? And when I was doing my informant interviews around the nation, I got a lot of responses ranging from this is a really important population. I have gay patients, please do this work, to I don't get why you need to study prostate cancer in gay and bisexual men. After all, I treat all my patients the same, through to I don't really understand what's going on. Let's take a look. I think that there's at least 4 reasons why we should be studying this population. I would argue that to accelerate science, we need to study phenomena in multiple different populations so that we look for exceptions. You look for patterns where things aren't falling the way they should. If we only study prostate cancer in heterosexual men, we miss an important opportunity. Second, it's epidemiologically informative. Our best guess is we have between 125 and 175,000 gay and bisexual men in the United States. And of course, gay couples are particularly interesting. They're the couple's configuration most likely to get prostate cancer because they have 2 prostates compared to heterosexuals 1. Clinically, it's critical. Clinicians need data to practice evidence-informed medicine. And there's some reasons to think about sexual functioning after prostate cancer treatment as different. Anal sex requires about 30% greater rigidity in the penis than vaginal sex. Data for heterosexual patients probably doesn't generalize. And ethically, it's imperative. We believe as a community of scientists that in justice, that we should be studying fairly across populations. Ignorance isn't bliss. And something that's profound in this community is the whole experience of HIV and AIDS that overshadows everything in gay health. What we don't know about gay health can and does hurt us. And I can speak both as a scientist and as a gay man. From the scientist perspective, those of us who were studying gay health, we all focused on HIV because that was the most important thing. I'm glad of that decision. It was the right thing to do. But it meant that we neglected other areas of health, cancer in particular. So let's talk about Restore 1. This was a mixed methods exploratory study involving qualitative interviews and quantitative online survey. It happened in 2015 and 16. And the recruitment was from an online social support group for gay and bisexual men with prostate cancer. So we did some qualitative interviews, and this was about 30 prostate cancer survivors, 19 with prostatectomy, 6 radiation, and 5 other treatments. And what we find out is that gay and bisexual men have questions that aren't answered in treatment. So some of the questions that are typical is, how long after surgery should I wait before anal stimulation? Can I tear anything? Can I use an enema? How long should I wait after surgery before restarting receptive sex? If I've had brachytherapy, can I push the seeds into my partner? And male partners, there's not a lot of good information on prostate cancer, surprisingly, in the gay community. And so there's a lot of fears and myths about whether or not this is an infectious disease. Can I get it from that? Treatment profoundly impacts gay and bisexual men's lives and identity. what we saw is like heterosexuals, you see a diminished sense in masculinity and potency, but there's also, the guys talked about feeling less than the average gay person. And then some men cope in novel ways that heterosexuals don't. So some men change their role and sex identity from being the insertive partner, which we call tops, to the receptive partner called bottoms. And some people can, and other people absolutely can't. And clinicians who assume that this is easy are making a clinical error. As this guy says, I hate it when people say, well, you know, as a gay man, you have an option. You can always bottom. It isn't that simple. You can't just change your sexual focus like that. I don't think I could suddenly become a bottom any more than I could suddenly decide to go out and fly a 747. Based on this, we've developed and published a new model of how the sexual challenges for gay men impact quality of life long term. And I can just walk you very quickly. We think what's central is the anatomical changes that lead to behavioral challenges, and then changes right across the sexual life cycle. These two seem to do a number on identity, on longer. So they have this change in role in sex identity. It's actually not a reversal from top to bottom. What guys say is that they used to have a role in sex identity and now I don't anymore. I've lost my identity. I don't know who I am. Changes to loss of masculinity and changes and loss to gay by identity, and then broader impact on quality of life, emotional challenges, disclosure challenges, and relationship challenges. Coming out to their urologist is critical, or oncologist is critical for many gay and bisexual patients to establish trust. And what we found was essentially 4 different strategies. Some people will not do business with a cancer specialist unless they're out. Others evaluate the specialist and then decide whether to disclose or not. The third option was to assume that the person somehow already knows, either because they assume that it was written in a referral letter, or because of mannerisms, stereotypes, or something else, that if this guy can't tell that I'm a screaming queen, then I want to go to another specialist. And then at the other end of it is guys who elect not to disclose, and for their safety, and they express also fears about poor treatment, that they will remain private about that information. What's interesting is what happens next when they do disclose, how physicians handle it, and this appears critical. So when physicians treat orientation disclosure sensitively, it builds trust. As this man said, I had identified myself as gay before the appointment. He knew that. At one point in the appointment, he invited my wife to leave the room. We talked openly and honestly at that point. But when physicians discount or appear uncomfortable, there was a consistent pattern that people leave treatment. Up to and including changing whether or not they get surgery or choose radiation, or just can't handle it. So it's a critical moment, and the way for clinicians who may be listening in to think about this is probably the most sensitive thing that a sexual minority person can tell you. So holding that information is trustworthy, recognizing it, honoring it, and then sensitively talking about how that may change the clinical implications are important. So after the qualitative interviews, we proceeded to do a quantitative survey. And for some of you, maybe an N of 193, it looks small, but it's about twice the size of every other study that had been done on this population, and there was only about 9 before that globally. So just to give you an idea of what happens in these online studies that we do, we had 95% of the respondents were from the US. These are predominantly a white sample, gay identified, HIV negative, with an average of about 6.7 years since treatment. And about half it had prostatectomy, and the remainder either radiation or other treatment. And as you can see, we've got good geographic spread from 38 states and Hawaii and Alaska to Canadian provinces. Our first hypothesis was that erectile difficulties would be common, severe, and negatively correlated with quality of life. And indeed, that was true. About 78% described their erections as less than good. 85% said the quality of erection prevented them from anal sex. And but interesting enough, on the sexual subscale, on the EPIC, they actually did better. Almost all gay and bisexual men want to be sexual post-treatment. And for clinicians, you can assume that your patients are trying to be sexual. As you can see here, over 91% reported at least one sexual behavior in the last 4 weeks. HIV, STI should be a major concern in the clinical population, but it's not on clinicians' radar screens. What we found was, I think it was 8 STIs since prostate cancer, or 8 people got STIs since prostate cancer treatment, including 3 with HIV. We've replicated this in the RESTORE study, RESTORE 2 in a larger sample, and we're seeing about 11% of the sample getting HIV or STIs. And so on Friday, I'll be putting in a grant to study this and try and understand what's going on here. We've got some ideas about what's going on, but we need to understand the natural history. If treatment is causing, and I'm emphasizing if treatment is causing HIV and STIs, or if it's a high-risk period for this population, we need to get a handle on that. Receptive anal sex appears far more difficult, and urination appears a common problem post-treatment. So this is the first study really looking at receptive anal sex and the effect of prostate cancer treatment on it. And what you see is the number of guys reporting pain in receptive sex doubles. So the pain in receptive sex is about equivalent to the studies that you see vaginismus in women. But after prostate cancer treatment, it doubles to about 35%. And as you can see here, there's large numbers reporting recent pain. Anodyspareunia, I had the honor of naming that sexual disorder. And that is pain in receptive sex, so severe, so common, that it prevents the sex from occurring. About 1 in 3 are reporting bleeding or irritation. So there's clearly more work to be done here in understanding it. In addition, over half the sample is reporting involuntary urination during sex or at orgasm. And from the HIV prevention standpoint, that becomes very important, because if the guy is worried about, to be clear, being smelly or leaking or urinating in somebody's mouth, they're likely to substitute more higher risk behaviors to compensate. So there's, it's a more complex sexual pattern. In this slide, I'll just orient you to this. This is the number of, or the percent of people who said that the following issues were discussed prior to treatment. And this is what they experienced. And I've only chosen the ones that about half or more experienced. So these are the most common problems that this patient population reports. And as you can see, clinicians do a great job of talking about loss of ejaculate, erectile difficulties, and urinary problems in general. But then you've got these 5 other problems that most guys have that they say was never discussed in treatment. Specifically, changes in sex of orgasm, loss of sexual confidence, changes to the penis, increased pain in receptive sex, and urinary problems during sex or at orgasm. We did find evidence of disparities on key treatment outcomes. Gay and bisexual men had worse urinary and hormonal function, but better sexual function than heterosexuals. And we also found evidence of disparity on longer-term quality of life. This patient population scores worse on overall mental health than heterosexual patients. That's not surprising. This population typically does worse on mental health which we think is secondary to minority stress. But it's better on physical health than published norms for prostate cancer. That's the first, we haven't really paid attention to that. And what are the gay men doing that maybe we can teach heterosexual men to do to have better over physical health, or is it just an artifact that warrants more research? Over to Elizabeth.
So Morgan and I are just going to go through some secondary analyses from the Restore 1 study. The first one we did was looking at the association between age and quality of life and other variables in our participants. And we found in general that older participants, as you would probably expect, had about twice as long since treatment. And a little more surprisingly, we're a little more likely to identify as bisexual rather than gay. And probably partially related to just general aging rather than prostate cancer treatment. Older participants had higher physical quality of life and lower mental quality, or other way around, higher mental quality of life and lower physical quality of life. But the most surprising finding there was that older participants were about 20 percentage points less likely to be out to most of the people they know. And there are a few implications of that, some that Simon has discussed in our qualitative research. Essentially, if older participants are less likely to be out to their providers, they are assumed to be heterosexual or asexual or non-sexual, and aren't getting the rehabilitation advice they need. And they're also more likely to be isolated and not receiving the social support that younger participants might be receiving. In another analysis, we looked at how HIV status impacted quality of life after prostate cancer. And we hypothesized that there would be a syndemic effect, essentially that HIV and prostate cancer would have this multiplicative interaction, and people with HIV would have worse overall quality of life and treatment outcomes. What we found was that overall quality of life was pretty comparable between the two groups, kind of implying that syndemic may or may not be true. But the treatment-specific outcomes were much worse in people with HIV than people without. And since this was a cross-sectional analysis, it's a little hard to tell, what came first and so forth, but we hypothesize that might be mediated by comorbidities. People with HIV had much higher rates of heart disease and other kind of cardiovascular, other aging-related illnesses, and so it might mean worse erectile function and urinary function. And now on to Morgan.
All right, so I examined the association between pets and mental and physical well-being as measured by the SF-12. So given that sexual and gender minorities are more likely to be single and have less social support, we were wondering, how does having a pet or not having a pet add to the stress of living with prostate cancer? So we found that dog owners were no physically fitter than other men, which there are inconsistencies in the literature around the idea of I have a dog, I walk my dog, I am more active, but we found we found that dog owners were not more physically fitter. We also found that pet owners had lower mental health scores compared to non-pet owners in our sample, which is consistent with pets being an added stressor. Exactly. The cross-sectional nature of this analysis lends itself to future research around these topics.
So let's repeat that question.
Sorry, was it just that people who had baseline lower mental health, were they more likely to go and get a pet to try to help with that situation?
Right. So again, the cross-sectional nature of the research design makes that impossible to answer. But further research can definitely explore if there's an added expectation of increasing mental health, which may prompt people to go out and adopt pets.
I also want to,
Could I just ask for the pet owners in the room, does that jive with what you know or think? Dogs. Let's start with dogs. I'm surprised. No? You're right.
They're both expensive and time consuming. And I think when you're trying really hard on your survivorship to take care of your own situation, it may be very hard to care for something else.
So I don't know if I'm not sure I can comment on what I think about what pets would do. I think it's great that you included this. It's a kind of a creative analysis to do in this subset, but it also depends on how you define stressor in your instrument, right? Like what was the stress that they were saying? What is the stress that you attribute to dog or pet or cat ownership, right? So I would say that before we jump to conclusions, we should look closely at the instrument.
Morgan, can you talk a little bit more about how we manage stress? I predicted this would be this point where everyone starts talking.
Or to measure mental well-being, and we looked at mean well-being among cat owners, dog owners, owners of both cats and dogs, as well as the comparator group, which did not report owning a pet. And this was limited to by the way the question was prompted. It did not, as it was worded, incorporate past pet ownership. Given this is an older population, it's quite possible many participants would have liked to own a pet, but were unable to physically or financially.
The other thing, to come back to the idea of the population, because in public health we focus very much on population-based stuff, is that on average this is a population far more likely to be single. And Dr. Capistrand, Ben Capistrand, did a number of analyses just looking at the experience of cancer in these men, and actually entitled one of his papers, "I was far more likely to go through cancer alone." And if you think about that kind of experience of not having anywhere to put my dog or my cat, not having anyone to look after it, and when I come back from hospital, if I have found someone, then I don't have my animal with me, you can start understanding why this might be a higher stress than something valuable at that critical time. So, just some limitations. This is all self-report survey from patients, but not providers. So we don't have the provider lens. It's a convenient sample. It's a relatively small sample size, and it's an area of study not well researched. So reliability and generalizability are not well known. Furthermore, recruitment from a social support site could bias results. In terms of strengths, it's a large qualitative survey, in fact the largest qualitative survey done on the population to date. We had good saturation, and we also were able to conduct some preliminary work with boyfriends and husbands, and it turns out that the boyfriends and husbands aren't similar to the wives going through prostate cancer treatment. They do some things quite differently. And then we did the largest quantitative study to date. It shows potential for recruiting online, and it was the first study, as Elizabeth showed, large enough that we can start to look at differences by HIV status and by age, and smaller differences that have been missing from the literature. Based on those preliminary studies, in 2018, I was awarded the first R01. I just wanted to let you know what's going on at the moment because it's very exciting. And this is the first randomized controlled trial testing if a comprehensive online rehabilitation program can improve the sexual and urinary functioning of this population. And so, does sexual and urinary rehab work for gay and bisexual men prostate cancer survivors? And furthermore, if you tailor it to the population so you're addressing their issues, is it more effective? And so we're testing the first specific rehab protocols for erectile difficulties in assertive anal sex, urinary problems during sex, and pain in receptive sex. This is just an overview of the intervention. While we call this an online intervention, every participant in the intervention group gets PDE 5i drugs, pelvic floor exercises, sexual exercises, a gay man's guide to good sex after prostate cancer, social support, and we're also doing a health coach, which has proven popular in a minority. If you want to know more about that, Elizabeth and Morgan have been both acting as coaches in that regard. This is the research study design. It's your classic randomized controlled trial. Because so little is known about recruitment, we've actually been turned that into an aim to compare what happens from urology and large centers, from online support sites, and from the gay community. And then they go through an eligibility screener. The biggest threat to validity in online studies is the fact that you never meet the patients. And so there have been a number of studies that thought that they were studying one group and they were actually studying another group. And based on that, we did extensive external validation to be in the study. After you passed the screener, you had an individual telephone interview with one of our staff for about 25 minutes where you described your whole experience being gay and your whole experience having prostate cancer. So we're 100% confident that these are real people, because those are not easy things to talk about if you haven't experienced them. And then you get randomized to an intervention arm where you have daily access to rehab for 2 years, or current treatment, which is standard access. The enrollment started from January and August 2019. We actually had our enrollment period for a full year, but we finished 3 months early. We've recruited 400, and it's actually one SM into the trial. One person has died, and we've had excellent retention at 3 and 6 months. So this is viable. It's opening up a whole new way to do research on cancer patients virtually. And I can mention more about that or turn it over to the staff if you've got specific questions around that. The final thing, when you're a very small field, there's only about 4 or 5 groups worldwide studying this. And so we got in contact with them and we decided to collaborate on publishing our results. So if anyone is mad keen on reading a boring scientific book, we published this recently as a textbook to guide patients and clinicians on experiences. Where are we going? As Heather mentioned at the start, I'm very keen on getting at least 2 more colleagues at this university to write R01s, get them funded. We've got an R01 on oropharyngeal cancer in this population in at the moment. We've got 2 more being written. We've got an R21 going in on Friday on HIV STI risk and what's going on there, and actually end-of-life decisions. And that's the last one is an R01 to the provocative question 9, how do we recruit small populations into cancer studies? And we want to see if we can replicate what we've done in Restore on prostate cancer across lesbians, gay and bisexual men and other cancers and transgender populations with cancer. So that's just a little bit of what we've been doing and how we hang out and have a good time. We have multiple investigators with expertise in this area. So please know that we are very interested in collaborating. I'm going to set a challenge to my colleagues with R01s. Think about there's been supplements published that if you are studying populations in general, there's supplements to study SGM in particular to try and overcome that record. We do, I believe we've got a good track record and good contacts at NIH. We know how to recruit this area too if you're interested in online recruitment, and we're very open. The School of Public Health, I think, has a reputation for open collaboration. So if we can be helpful in any way, please just let us know. Finally, this is highly multidisciplinary research. You can't, it's not one person doing it. I'm not the PI, it's a team that is the PI. And I want to thank our colleagues across 5 schools at this university who have come together to do this type of work. And you can see them up there. So, and my email is there if anyone wants to follow up, and my phone number. Let's open it up to questions, thoughts.
So sorry I arrived late, and I'm also more sorry that I didn't get to know about your work when I was practicing in San Francisco, where I had 400 prostate cancer patients in my practice with a large proportion of gay men in practice, and had an opportunity to get to know many of them very well over a long period of time. I'm surprised maybe I missed it, but I think there's a real opportunity.
Actually, can I just stop you? Would you mind introducing yourself by name
Sure.
to the people at other sites?
I'm Chuck Ryan. I'm a medical oncologist here. I've been at the university for 2 years. I came from UCSF where I practiced before, and I focus on prostate cancer. I'm surprised, and I see a real opportunity to study the impact of hormonal therapy on sexual minority patients. And you know, my anecdotal experience is that in many aspects the response to medical castration is different, and in many aspects it's very similar between heterosexual and gay men. And I think that there's a real opportunity. I should also point out that I have a funded project with a colleague where we're studying cognitive impacts of androgen deprivation therapy with questionnaire type data and cognitive testing. And alongside that, it would be very easy, I think, to identify patients if we were to be able to recruit bisexual and gay men into our studies to do similar studies alongside in parallel with our cognitive studies. So just an opportunity that might present itself.
I think that's a natural opportunity. I'd like to, first of all, it's lovely to finally meet you, Chuck. We've actually, I put you, I think, on 2 or 3 applications, and this is the first time we've been in the same room together. So welcome to the university, a very belated welcome. Nick Ryder is probably a colleague that you want on your radar screen. They are in family medicine. They specialize in gender minority health, transgender and hormonal effects there. And a quick discussion, we can get the 3 of us together. I think I would love to see a study comparing the use of hormones in cancer treatment versus the use of hormones in for gender care. It sort of would be so cool and to take a look at how voluntary versus involuntary, I'm not quite sure how to frame it, but Nick Wright is one of the most exciting people, and we have a large transgender care center here, so we can talk. Thoughts?
So you had discussed some of the difficulties in using these online questionnaires, and when the patients come to the study, you don't know whether they really are who they say they are. Mm-hmm. And so in the course of this 25-minute interview where you discuss their experiences with being a gay male and also with having prostate cancer, does that eliminate any people from the study? Like, is there in your experience in this study, were there a lot of men, you know, pretending to be somebody they weren't just to be involved in something? Like, what are the reasons for something like that happening?
Thank you, Dr. Dem. Just to point out, online studies have huge strengths. That geographic spread you saw, the ability to recruit relatively small or rare populations and bring them together. There's nothing better than the internet, right? The biggest weakness is if you get fake responding, it can be really big. One of our colleagues, who shall remain nameless, did a study of 1,000 people, who were meant to be one group living in the United States, and they turned out to be different. In Restore 1, we rejected over half the sample, about, how much was it? Was it 55% of the sample? As probably fake. And those 4, we could tell them, first of all, it's highly unusual to have 50 people filling in your survey at 2 a.m. in the morning. That's a clue. My surveys are terribly, terribly exciting, but they're not worth waiting up to 2 a.m. So time of day, there's a whole protocol we developed. Time of day, you watch the surveys come in, and what we would see is somebody would take a survey for 9 minutes, 2 minutes off, 9 minutes, 2 minutes off. People get too good when they do practice effects. So gradually it's like, I can't fill in my survey in 9 minutes. How's this person doing it? We think the best I can tell is that 3 of those, the 255 surveys came from 4 sources. We're confident of that. 3 were probably human. Because the second challenge you have is you now have people writing computer programs to troll for surveys, find surveys, and then you've got smart learning algorithms who are getting better at working out how to get into the study and then do that. So there's a plus and minus of every single thing. We couldn't do this research if we did it physically because it's too hard in any center, even San Francisco, to get people to come in. And if you do it in a town like San Francisco or another town with a large concentration, what you tend to do is get atypical effects because the community has a cohesion that it isn't generalizable to anybody else. If you've lived in the Castro, you have a whole experience that is very different. So I take the view that online research is the way of the future. It's the way that every smart researcher should be thinking about it, particularly if you're studying smaller populations. But it definitely has a plus and a minus. And the more that you have a threat to validity, the more you need to do what's called deduplication and cross-validation. The deduplication refers to the fact that if you're offering sizable compensation, some people are in need of funds. And so we had one person who we labeled subject naught who filled in our survey 22 times. Forgive me, 72 times. And never used the same computer, but all the ISPs were related. So they were in a computer lab of a certain university, not in this state. It would never happen at the University of Minnesota, but it happened at another university because we could trace the IP addresses. And it's only with a strong deduplication, strong cross-validation. But when you interview people, that immediately decreases the likelihood of overseas people trying to get in, because we require a US unique telephone and email, etc. So there are ways of handling this. But that said, in research, this is one of the fastest evolving areas across all online. Yeah. Cool.
We didn't see any data from the Restore 2 trial, but based on the numbers from Restore 1 trial, what are you doing to increase the racial diversity of your sample?
Yeah. Really good question, and it's really important because African Americans in prostate cancer tend to have worse outcomes. There is one study that has come out of Chicago with a sizable, as in 30 African Americans, I think they was in their study, and that's the only study in the field of sizable racial ethnic minority involvement. I have 2 reactions to it. First of all, we're doing everything we can, and we're probably doing some things that are unfortunate. That when you look at racial and ethnic populations, about 10 years ago, we used to worry about the digital divide excluding, especially lower socioeconomic status. We no longer talk about the digital divide because African Americans and other minorities are online as much. What is different, as much as white and majority populations, what is different is how they're online. They're far more likely to be online with a phone. And that turns out to be important because if you're going to fill in one of Simon Ross's surveys with 255 questions, it's miserable to do it on a phone versus doing it online. So procedurally, we were worried about that because that would lead to higher drop-off and just people getting exhausted. We don't yet have the methods, and it may be a standard too far for us to get to. I have contacted, I think there's please forgive me, I've forgotten the name of the researcher, but they're doing the 10,000 African American prostate cancer patients study, and we've reached out to them and said, look, if you've got anyone who's LGBT, maybe that's a better way of getting into it. But we don't have good methods to do it this way. The other thing I would say is we don't ask racial and ethnic studies, how many gay men do you have in your study? So is it a fair question to ask the one gay study? So, but it's a really good challenge, and we're up for the challenge, and we will invent the methods, and we will get there.
Other questions, comments? All right, well, let's thank Dr. Rosser and his team.
And thanks again. If we can collaborate or be helpful, please don't hesitate to contact us.